Soka. Our next speaker is Dr. Vasant Stalin. Dr. Stalin is the Director of Bariatric Surgery at Ascension in St. Mary's Hospital, and he's going to speak to us on providing culturally competent care in an increasingly diverse world. Thank you, Dr. Stalin.
Well, thank you, first of all, to SAGES for inviting me over here to speak. I have no disclosures with regards to this presentation. So first of all, let's talk about population diversity demographics. What do we mean by an increasingly diverse world? If you look at the data, by 2050, racial and ethnic minorities are going to be comprising about 35% of the US elderly population, and about 20% of the US population is going to be elderly. Needless to say, this population becomes increasingly, as this population becomes increasingly diverse, we are going to need more attention to linguistic and cultural barriers to care, and that's going to be of paramount importance. So what exactly is culture? There are various definitions out there, but I found this definition to be complete. The personal identification, language, thoughts, communications, actions, customs, beliefs, values, and institutions that are often specific to ethnic, racial, religious, geographic, or social groups. And individuals' cultural affiliation can affect how, when they seek care, how they describe symptoms, and how they select treatment options, and it's even going to determine whether or not they're going to follow your recommendations as a provider. These are all some of the factors that can affect culture as far as the patient is concerned. What is cultural competence? Cultural competence in healthcare refers to the ability of systems to provide care to patients with diverse values, beliefs, and behaviors, including the tailoring of healthcare delivery to meet patients' social, cultural, and linguistic needs. The term cultural competence has previously been usually used with relation to racial and ethnic minority groups, but of late it's being used to encompass other groups such as people with disabilities and the LGBTQ community, amongst other groups. Cultural competence has also become linked increasingly with health literacy, and this broadening of cultural competency is being even reflected in the updated standards for culturally and linguistically appropriate services, which is CLAS, as defined by HHS. The goal of culturally competent healthcare is to provide the highest possible quality of care to every patient, regardless of what race they are, what ethnicity they belong to, their cultural background, English proficiency, or literacy. So these are some of the strategies that you can use to improve cultural competence, both with your own practice and with in the institutions that you work at. Interpreter services are important. Recruitment and retention of minority staff go a long way. Providing training to improve cultural awareness, that's important. Coordination with traditional healers, using community health workers, incorporation of culture-specific attitudes, inclusion of family members and community members in medical decision-making process, location of the clinics in particular geographic locations that are easily accessible to certain populations, and providing linguistic competency services that extend not only to your visit, but also to other associated things like the appointment desk, advice lines, medical billing, other written materials. These all become very important. It's almost impossible to know everything about every culture. That's taken for granted. However, there are certain training approaches that can actually lead to better outcomes and understanding of cultural competence. For example, skills such as communication and medical history-taking techniques, when combined with other attributes like curiosity, empathy, respect, and humility when dealing with patients, can go a long way in getting the patients to yield useful information to you that can only lead to overall better outcomes. So approaches that focus on increasing knowledge about various groups, typically through a list of common health beliefs, behaviors, and key do's and don'ts, provide a good starting point, but you don't want to end up stereotyping patients and ignoring variations within a particular group. For example, when you loosely use the term a Latino patient, you may be talking about anyone who might be a first-generation immigrant from Central America to a sixth-generation Mexican-American living in Texas. And even amongst those folks, there are variations depending on the level of acculturation, citizenship or refugee status, how long they have spent in the US, circumstances of immigration, etc. And those differences are important to recognize. So the Office for Civil Rights has published something called Title VI, Prohibition Against National Origin Discrimination as it affects persons with limited English proficiency. And this is coming straight from the Department of Human and Health Services, Health and Human Services, DHHS, and it's a federal standard. There are other standards in place. So for example, in August 2000, CMS Medicare issued guidelines to all state Medicaid directors regarding interpreter and translator services, and they even emphasized that federal matching funds would be available when those services are instituted. In 2000, DHHS issued 14 national standards on culturally and linguistically appropriate services called CLAS in healthcare. In 2002, CMS has issued a couple of guides to assist with managed care plans, providing oral and linguistic services, and planning culturally and linguistically appropriate services. So this cultural competency drive outreach also extends to training programs. So for example, you see the Society of Teachers of Family Medicine guidelines, and these are the guidelines that pertain to the education of family practice residents in residency training. We see the same level of commitment by bodies such as LCME and the recently mandated higher standards for curriculum material on cultural competence than were previously required. You also see numerous healthcare systems increasingly implementing cultural competence strategies just because they are a good business practice, amongst other things, that increases interest and participation of both providers and patients in their healthcare plans amongst racial and ethnic minority populations. So there's a lot of data that cultural competence, lack of cultural competence training may lead to patient dissatisfaction. If you look at African Americans and other ethnic minorities, they report less partnership with physicians, less participations in medical decision-making, and lower levels of satisfaction with their care. African Americans, Latinos, Asian Americans, they're all more likely than a white population to report that they believe that they would have received better care if they had been of a different race or ethnicity. African Americans are more likely than other minority groups to feel that they were treated disrespectfully. Asian Americans are least likely to feel that their doctor understood their cultural background. The quality of patient-physician interactions is lower amongst non-white patients, and it's associated with lower overall satisfaction with healthcare. Racial and ethnic minorities also have higher morbidity and mortality from chronic diseases, resulting in greater financial burden and higher activity limitations. If you look at the older adults, a higher proportion of African Americans and Latinos, as compared to the white population, report that they have at least one of 7 chronic health conditions in a higher proportion. African Americans and American Indians are also more likely to be limited in activity due to chronic conditions. Language barriers are very important in this whole scenario, and there are more than 37 million adults in the United States who speak a language other than English, and 48% of them speak English, quote unquote, less than very well. So language and communication problems lead to patient dissatisfaction, poor comprehension, low quality of care. Spanish-speaking Latinos, for example, are less likely than a white population to visit a physician or a mental health provider and receive preventive care, such as mammography or even vaccination. Spanish-speaking population get less satisfaction from healthcare providers as compared to English-speaking native population. And amongst the English-speaking speakers who need an interpreter during a healthcare visit, only 48%, less than 50%, reported that they had such an interpreter in place. Linguistic disparities become all that more important, especially when it's an interaction between a surgeon and the patient. And studies have shown that patients who do not speak the same local language are at a disadvantage in terms of access not only to healthcare facilities, but these barriers also result in poorer healthcare outcomes. There are numerous language assistance strategies that can be put in place to mitigate this impact. Having bilingual clinicians, staff, qualified foreign language and American Sign Language interpreters are just some of those strategies. And this can result in better safety outcomes. For example, you don't want a scenario where an X-ray has been performed on a wrong part, or maybe a patient falls because they didn't know how to ask for assistance, or maybe an ER physician couldn't properly treat a patient because of lack of good medical history. And providers shouldn't try to just get by with the limited English language skills of patients or their own inadequate understanding of a foreign language. Bilingual and bicultural services can be effective in such a scenario, and these services are typically best developed in Asian American and Latino communities. ACRS is one such community-based mental health organization, and in fact, the ACS curriculum will actually be used as a model for a national mental health interpreter training project to address the needs of the limited English-speaking population. Racial and ethnic minorities are also more likely to have lower levels of literacy, often due to cultural and language barriers. And these translate into this population using more health services, and the resulting healthcare costs are estimated to be up to $58 billion in additional healthcare expenses. So literacy level should certainly be assessed, either using formal or informal means when you have any such cultural competency issue during a patient visit. And cultural brokers can also be used to enhance cultural competency. Any individual who acts as a cultural broker should be a trusted and respected member of that particular community, but does not necessarily need to be a healthcare professional. Cultural competency training programs aim to increase cultural awareness, knowledge, and skills, leading to behavior change. Cultural competence training has positive impacts on provider outcomes, but just a standalone strategy in training the provider alone may be insufficient to improve patient outcomes without concurrent buy-in from a systems perspective or from an organizational change perspective. AHRQ themselves have something called a RED toolkit, which is the re-engineered discharge toolkit, which includes a set of 12 actions that hospitals should take during and after patient stay to improve the discharge process. The RED toolkit also includes implementation guidelines for delivering RED to patients with diverse culture, language, race, ethnicity, literacy, sexual orientation, gender identity, etc. So the toolkit highlights how to implement each RED component with modifications in diverse patient populations. Research has shown that RED is highly effective in reducing readmissions and post-hospital ED visits. AHRQ also has something called the TeamSTEPPS module, and implementation of this module has shown improved safety outcomes in a hospital population. So in conclusion, cultural competence is not just an isolated aspect of medical care, but an important component of overall excellence in healthcare delivery. Improved communication helps the healthcare provider collect accurate medical information and ultimately keeps the patient safe. Removal of discrepancies due to culture and language also keeps the patient confident and helps build trust. Efforts to improve cultural competence amongst healthcare professionals and organizations would contribute to improving the overall quality of healthcare for all consumers. And lastly, it's important to understand and appreciate that cultural competence is a process rather than the ultimate goal, and is often developed in stages, building upon previous knowledge and experience. Thank you so much for giving me the opportunity to present this talk.
If you would please join us here for the panel discussion. And thank you so much for this overview and the importance of cultural competency. Our final speaker is Dr. Jessica Gorham. Dr. Gorham is the Associate Program Director at Ochsner Medical Center in Louisiana.
For that data, those data, both for gender, as well as gender identity, as well as also ethnic identity. One of the hospitals I worked at was so outdated that they actually had numbers for race, and that was the majority of the data capture. So what are the processes for going to administrators?
Yeah, at Ochsner a couple years ago, we actually were able to successfully, after a couple years of trying, turn on some of these already built-in opportunities within the EMR, at least within Epic. I guess I can't speak to some of the other EMR systems. But a few things that we've been able to do are, when a patient comes in, they give us their preferred name. And so regardless of whether that's on their official documentation or not, what pops up when that patient shows up on my clinic is their preferred name. And it's not in quotation marks or anything like that. So when I first meet that patient face to face, that is my, to my best knowledge, how to address them. Same thing goes for the sex and gender orientation. What actually shows up primarily is gender orientation, and you have to go searching for their actual biological sex. I think, to dovetail onto the first question, that has also helped a lot of physicians who don't necessarily know how to navigate those conversations to go into that room a little bit better prepared, because they're not making incorrect assumptions when they first walk in. And having that comfort with the patient and them in the room, a part of that gap, maybe not all of it, but a part of it has certainly already been bridged. You can filter through those biological sex and gender identity when you do research projects, and so none of it gets lost. It just changes, you know, the face sheet when you go in for the day. So it can be done. It just takes a little convincing that this is something that's important, and it obviously is.
And there's absolutely institutional barriers to this, which can be hard. So in our experience advocating for this, they said, well, yes, it's there, but if we turn it on,
even if it's very obvious what you identify as, when we see that, it's the kind of an implicit clue that this is somebody who's safe for us to talk to. So finding those little small things that you can do. Again, the Zoom thing is huge, just having your pronouns after you, like, then we immediately know that you're somebody who at least identifies with the cause. So finding small things like that, I think, is helpful.
We do have a question that was submitted. As a non-American born surgical trainee, at times I have at my own program faced racially and or sexually prejudiced comments, although they were not necessarily made maliciously. It can be uncomfortable and difficult to face those situations. Any advice on how to handle those situations? I'll ask Dr. Stalin or Gorham, if you'd like to answer.
So, unfortunately, I think this is a fairly common situation where there is some sort of either, if not open bias, implicit bias that may or may not be directed at you personally, but you pick up on these things during the course of your training or day-to-day activities. It certainly should start with, it shouldn't be taken lightly. I think it should always be reported so that appropriate corrective action is taken. If it's never reported in the first place, then no one even knows that such a problem exists. I think that's where it should start. There should be no fear of reprisal, and a neutral environment should be maintained that is conducive to ironing out these issues as far as the residency program is concerned. And there should be no systems inhibitions to such process being put in place.
Thank you, Dr. Stalin. In the interest of time, I know we were in the middle of a robust discussion, but our time has ended. I think this means we need more discussions, and we need to be able to put these into further initiatives. So thank you very much to this panel, and thank you to this audience for being engaged. Thanks, everybody.